So this is the CT scan on which the entire discussion is going to be based today. If the report has to be said, then it is 14 by 15 centimeter with thrombus, which is found, and extrahepatic. Some lymph nodes were seen, and there was a minimal ascites, which was seen in this patient. So this is where it is. So I would like to start with Dr. Ghanshyam Biswas and Dr. Venkata Pradeep Babu Koyala. I think in the previous panel, it was very crystal clear defined, but just to start the panel, Ghanshyam, in your practice, when would you say no to TACE? Or, you move on to systemic treatment, TACE refractoriness, if you can just revise, because Tarini has done it very well.
Yeah, sure. So vascular invasion, so M1 disease, lots of extrahepatic disease. So these are cases where, or a bilobar disease. So these are not a case of TACE.
Okay. And if somebody has done TACE, when do you want it to be shifted to systemic treatment? And do you say that, TACE no longer, don't do further TACE?
So TACE is for, we understand this is for a loco-regional disease, but since still some palliative cases for a large tumor, we know that is causing symptoms. So we at times do, but yeah, patient who has ascites, we understand that this patient has a large thrombus, so they won't benefit with a TACE, and TACE won't be done at this patient. So these are the patients where we need to go for the systemic therapy.
Perfect. Dr. Venkata Pradeep, assuming that there is no extrahepatic disease in this patient, it is just what you see here in this CT scan slide. When do you say that above certain size, TACE is not to be indicated? Is there a size which is defined that beyond this size, there is a relative or an absolute contraindication for TACE? One, and second thing is, if you have performed one TACE or two TACE, when do you say that enough is enough?
So regarding the size, it is not exactly mentioned beyond which actually TACE cannot be done. So usually the systemic therapy is for those patients for BCLC D. So it is, as Sir has mentioned, for extrahepatic disease, major vascular invasion, and patients with PS 1 to 2. And regarding the second question of when we say that no more TACE, one, when the patient is unable to tolerate a procedure, and LFTs are deranged. So I think those are the 2 points which I understand are the things.
Right. Viraj, can you just summarize when enough is enough in terms of TACE so that we can move on?
This patient, first of all, will never go for TACE if I were to see him. That's number one.
Why? Size is the criteria for you?
More than 10, we don't do TACE because we don't have tear, so that discussion is completely out.
Correct.
And like other panels said, extrahepatic disease makes it out. And vascular invasion, major vascular invasion makes it out. And AFP levels, people often don't talk about AFP levels. Let's say this patient has 5,000 AFP. I'm definitely not going to do him TACE. I will consider systemic treatment.
Right. So Viraj, according to Viraj, alpha fetoprotein also makes one of the criteria. This is something new I'm learning, Viraj. I think, what you said, about 10 centimeter out of 5 guidelines for TACE. There is one Asian guideline which have said that about 10 centimeter you should not consider TACE. The answer what I was looking for and what Tarini said, that if you have performed TACE twice, and if there is no response, and if the liver function is going down, you should not do TACE third time, and you should move to the systemic treatment. So based on that, let's completely move to a multidisciplinary team, MDT. We have been discussing MDT, a lot. And there are some papers which say that MDT improves survival, and it is a must in HCC. I would like to ask Dr. Poonam Patil. Dr. Poonam, do you think MDT is must in treating HCC?
Yeah, especially in those gray zones where you are not very sure whether that patient is 100% not going to require any local therapy. that is the place where MDT would definitely be important. If the patient has got clear-cut extra hepatic disease, widespread metastatic disease, I know that there's no local therapy really that's going to be.
You have the radiologist to tell that report. Why do you need MDT for that?
Yeah,
the radiologist tells you there is extrahepatic disease. You can see there is ascites.
Yeah, so if the liver functions are fairly okay and the patient is very symptomatic due to the liver disease, and there if I feel, as Dr. Ghanshyam Biswas had mentioned earlier, that if there is a place of taste with a palliative intent there, maybe those kind of regions I would probably take an opinion of MDT. Otherwise, if the patient
Otherwise, no.
No.
But Dr. Kshitij, what do you think?
Yeah, I agree with Dr. Poonam Patil, madam. But what I consider multidisciplinary team also includes other specialists like gastroenterologists and all. So there will I will divide into two parts. First is for borderline, because we know only curative intent is a local treatment. So that's why whenever there is something borderline that we can convert as a bridge to resectable or that we convert into local treatment, where I can take opinion of a MDT.
This panel is about advanced HCC.
And the second thing
in
is
advanced HCC. Yeah. Please go ahead.
HCG, many HCCs are HBV positive, HCV positive. We need a treatment for that. Also, if you decide to use bevacizumab, atezolizumab, we need to do an endoscopy and banding before using bevacizumab can cause bleeding. So I think multidisciplinary approach is always required.
Is always required. Excellent. Viraj, just yes or no. Does MDT in advanced HCC improve survival? Yes or no? Yes.
Yeah.
Okay, perfect. So let's see this one particular paper from Korea, and they were said that this improves the survival. And the next slide, I want you to see in the focus what I have said, that 71.2% is the 5-year survival compared to 49.4% 5-year survival. And they have specifically said that this is very important in patients with poor liver function, intermediate to advanced stage, the last line if you see, or very high alpha fetoprotein, that is more than 200. Again, I would say 71 versus 49.4 5-year survival. This is amazing. Dr. Rishabh.
So Amish, so
yes,
why Amish, why in an advanced HCC 5-year survival was taken? So that was my question.
No. It is all stages put together.
Achha, all stages.
All stages. Come on. If advanced 5-year, I would go to Korea to do fellowship, Baba. Dr. Rishabh, do you agree with these results? I was surprised looking at this paper. We have Dr. Rishabh?
Yeah, he's there. He's there.
I think maybe they have more screen detected cases or so.
Dr. Kshitij, do you believe in these results? I agree MDT helps, but does it improve survival to this extent? If then 100% all HCC should be treated through MDT?
Practical experience in Indian scenario, it is not the real life. That is what I think.
That is what I wanted to bring forth. In fact, in this paper, they have said one-time MDT versus regular MDT. And like Dr. Poonam Patil said, is that if you have a good liaison with a radiologist and a gastroenterologist, yes, MDT is helpful, but it is not mandatory to treat HCC in a country like India. You don't have MDT everywhere. That is what I wanted to bring forth in advanced HCC especially. Dr. Viraj, how important is Child Pugh score in your clinical practice?
So I score for everybody. Child is something which goes automatically on my consulting paper. But I feel this score is slightly inaccurate when we select patients. And I often have debates with my other colleagues. Let's say, for example, you have albumin of 3.4 and INR of just 1.5. That will make B7. Now, as a whole, patient, when you say B7 to somebody, and if I say albumin 3.4 and INR 1.5, that is what has made B7, you would not take, compared to, let's say, patient has ascites or bilirubin is 3, that B7 is different. Also, the bilirubin direct versus indirect is not mentioned here. Let's say you have bilirubin 3, but direct is only 1, indirect is 2. What do you take? So I think there are fallacies of child scoring. Nevertheless, we use it for all patients.
Dr. Poonam Patil, would you want to add something to what Dr. Viraj said?
No, I fully agree with him. It's a very fluid score. And you have to see to a particular patient how you would extract best out of this score.
Okay, perfect. Dr. Ghanshyam, if ascites, slight ascites score is 2, no encephalopathy 1, less than 2 bilirubin is 1, that is 4 score. Albumin is less than more than 3.55, prothrombin time 1 to 3, 6. So you are in A. But as Viraj said, is that if your bilirubin is 2.2, this makes Child Pugh B. Do you put significance in your clinical practice, Ghanshyam? Because this is daily thing. And why I'm asking this question is that if you see in this NCCN guidelines, if you have Child Pugh B, the only thing in the first line which is approved is sorafinib or nivolumab. Of course, FOLFOX always is there, but sorafinib or nivolumab. Ghanshyam, and then
so definitely when you see an SCC which requires a systemic treatment, so definitely, so you are going to do a Child Pugh score. So yeah, so that is actually a reflection of a functional status of an underlying cirrhosis. And definitely, so if you can have the burden of disease, so function of liver function and the burden, so if they are put together, then probably it makes more sense. And definitely these patients.
Ghanshyam, in your practice, in your clinical practice day to day, Child Pugh B7 because of bilirubin 2.2. Do you take cognizance of that or do you not?
No, so in my heart of hearts, I'll consider that as A and give the treatment.
And give the treatment. Chitij, in your heart in heart, Supreme Court lawyer may not agree with your heart in heart comment. Dada can escape anything.
I agree with Dr. Ghanshyam, sir. But what I want to point out that there is some Japanese assessment of this that suggests that even if it is a Child Pugh B, lenvatinib works well. So considering that, so with more than 50% involvement and rest of the things, where we
India, unfortunately, we go by US FDA and DCGI approval.
But we can extrapolate the data, and if it is a borderline situation, I would like to.
So in your clinical practice, you would consider this as a borderline. You would treat as Child Pugh A. I'm very, very interested by these panelists, and I'm very happy that they are saying this. Dr. Rishabh, would you do the same in your clinical practice?
Sir, B7 is something where I have given lenvatinib. I have not given ATS plus Bev in B7, but I have stretched B7 for lenvatinib.
B7 for lenvatinib.
Lenvatinib than sorafinib clinically, not medico-legally.
Not medico-legally. Dr. Poonam, you would agree on the same? You would extend lenvatinib to B7?
Yes, it depends on what criteria am I following, like Dr. Viraj told earlier. So it depends on the criteria. But yes, when you talk or hear about medical legal, our ears go up and we try to become defensive there. So
okay, you are absolutely right. We all have to be very, very careful in the wordings, and that's what I wanted to say. But I completely agree with you. This frustrates all of us out of the just 2.1 and 3.4 of albumin really is frustrating. Let us first stick to Child Pugh A and then come to Child Pugh B, because we need to cover advanced HCC. I want to cover first and second line if it is possible, if the time allows us. Category 1 recommendation or the FDA approval in a randomized controlled trial in Child Pugh A systemic treatment is 3. Sorafinib, lenvatinib, and atezobev. Which one and when? Dr. VP, Dr. Venkata, Pradeep, Babu, I can start with you.
Right, sir. So I don't have the privilege of using atezo plus bev in my practice, sir. So ultimately, we end up starting sorafinib. So most importantly, when performance status is good, along with the Child Pugh score, the one most important is looking after the performance status, liver hepatitis panel, and affordability. So ultimately, we end up starting sorafenib, and based upon tolerance, sometimes lenvatinib. So
Tolerance
this is how
sometimes.
my
So
practice is.
tyrosine kinase inhibitor is the cornerstone for your practice. Dr. Rishabh, I'm sorry, I think in this slide I have spelled your name incorrect. Dr. Rishabh, what would you and when?
Sir, so atezobev, if patient is child pug A, no varices or treated varices, and financially feasible for the patient. Rest of the scenario, initially I was giving sorafinib only for B7, but now I'm switching to lenvatinib for B7. Else, most of the situation, I'm giving lenvatinib over sorafinib. I find it more tolerable than sorafinib.
Okay, excellent. Viraj, I just want your comment on this. This is very fascinating. In sharp trial sorafenib, there was median OS was 10.7, and now when you look at the reflect trial and when you look at IMBAVE, somehow sorafenib, the placebo arm has jumped up to 12 and 13 months. Where
It's
have we
definitely
gained these
not
2
switch
months,
effect,
Viraj?
if I'm not wrong. Cases in these patients. The other one was pure BCLCC. And I agree with Rishabh, all of my patients are on lenvatinib, and if they can afford it, it's okay. But no sorafenib for last 2 years
Okay,
now.
excellent. So Ahmedabad is getting free of sorafenib. That is very interesting to note that Gujarat is getting free of sorafenib. Viraj, please remember in RCC it is the other way around. The sunitinib is losing median OS when the newer and newer trials, and you wonder at what is wrong with sunitinib in the control arm. Okay, so we are going to do some rapid fire round, and I just want you. Which particular drug would you choose in this scenario? Would you not choose in this scenario? Dr. Ghanshyam, a patient has active hepatitis B or active hepatitis C.
So in hepatitis C, sorafenib did a better OS of 14 months. So hepatitis B, it can be a lenvatinib.
Can be a lenvatinib. Would you give atezobev in active hepatitis B and C?
No, so they had to be on antivirals for at least 4 to 6 weeks, and then only you can start.
Okay, and in addition to that, the copies of the viral particle has to be less than 100. That is what I had said. Bleeding from varices, Dr. Poonam Patil, what would you give and what would you not give?
So first, anyway, we will control the bleeding by endoscopy and banding or whatever argon laser, whichever way we will control that, and then we can go ahead with either. We can go ahead with atezobev if the bleeding is constrained, or maybe lenvatinib.
How long would you wait after the banding for starting them on immunobev? Ma'am, 6 to 8 weeks is what they have said, that if there is no repeat in the bleeding. But in our clinical practice, do our patients wait for 2 months? Whereas in your patient, would patient wait for 2 months for you to start treatment?
So I had just one case where I'll tell you what I did. I just started immunotherapy and didn't add the BEV part because it's the BEV which is the problem.
Okay, wow. So Viraj is doing this. Dr. Chitich, uncontrolled hypertension. What would you use and what would you not use? Patient is uncontrolled, has gone to 2 physicians and just blood pressure is not under control.
Yeah, I will not use lenvatinib because the hypertension is a side effect of lenvatinib. Sorafenib sometime or nivolumab or this.
So either sorafenib or nivolumab, and you would not give atezobev combination also because of uncontrolled hypertension.
Yeah.
Okay, perfect. Dr. Viraj, not Dr. Poladiya, transplant and now recurrence, what would you give?
No immunotherapy.
There are some trials which I agree with you, but there are some trials which are coming that if there is a delayed recurrence after 2 years, you can safely use immunotherapy. But I agree, overall, we should not use. Major portal hypertension. Dr. Venkata, Pradeep, Babu, what should you not use?
So for systemic hypertension, definitely I would hesitate to start lenvatinib, sorafenib.
No, major portal hypertension.
Yeah, for portal hypertension, I do not know any specific contraindication, but I would start TKI, so lenvatinib.
You would start TKI, lenvatinib. Chitish, would you agree with that? Would you start lenvatinib in major portal hypertension?
Sorry, I missed the question.
Major portal hypertension. Would you start lenvatinib or would you not start lenvatinib? Anybody? Ghanshyam?
Yeah, so lenvatinib is preferred over sorafinib with a major
Yes.
portal hypertension.
Okay. दादा ने कुछ बोला है, तो probably I don't agree on that point. But Viraj.
So in the reflex study, the portal vein invasion more than 50% were not taken in the trial. So lenvatinib causes more hepatotoxicity in these
Absolutely right. There were more and more hepatic encephalopathy noticed in reflect trial, especially when lenvatinib was used. And in fact, this is one of the relative contraindication where you should not use lenvatinib. I think everybody has answered. Viraj has answered. I'm quickly going to go through this. I just wanted to say that even though there was a non-inferiority trial, but lenvatinib scored over sorafinib, in a nicer way. And I think more and more of us are shifting to lenvatinib rather than sorafinib. Dr. Rishabh, would you not use lenvatinib in any other scenario apart from portal hypertension?
So, sir, as I told that most of my patients are now on lenvatinib. B7 was something where I was giving sorafinib alone. Now I'm already shifting for B7 to lenvatinib.
Okay, so
Can I add
I would
one
come
thing?
to B7. Yes, please.
Just when this was in the trial where lenvatinib was approved, there was a discrepancy between AFP levels, and when they randomized and they removed that AFP discrepancy, they found that lenvatinib overall survival was better than sorafinib. So that lenvatinib is preferred over sorafinib unless and until it is contraindicated. That is my interpretation.
You are absolutely right. Only thing is that was not a pre-defined or predetermined, determinant in the reflex study, and that's the reason you have to take it with a pinch of salt. But I completely agree with you. If one wants to choose sorafinib, is there any prognostic model, Dr. Ghanshyam?
Yeah, so there are certain prognostic and predictive markers like the albumin, bilirubin, the alpha fetoprotein, so the vascular invasion, extrahepatic disease, and the tumor size. So that was a process, and then subsequently a process 2. So they are categorized into 4, and which shows that the which was a grade 1, so they did better, and the grade 4 the risk means the risk grade. So 1 versus 4 is 16 versus 4 months.
Okay, you are absolutely right, and this is one paper which from the Netherlands and Netherlands and UK both, which is there. Dr. Rishabh, do you follow process risk model, especially in India? Of course, you are not using sorafinib so much. I'm not asking Viraj because last 2 years he has not used sorafinib, but Dr. Ghanshyam Biswas works in a place where financial toxicity is almost everyday struggle, and I think this particular model may help us. Kshitij, do you think that if we have a model which can predict a good survival, so if I'll give you this, if there's a risk group 1, the median OS was 16.9 months. This is much more than the reflect, and this is definitely much more than the routine 11 months of sorafinib in all the trials. If you get such risk model and we validate in India, do you think Indian population will benefit out of this?
Well, definitely we can use that more, because if it is giving a benefit of 16.9, which is very significant benefit.
Absolutely,
then I would
I
like to
completely
use
agree
it.
with you. Dr. Poonam, do you think that if the model is validated, would you start using this model from tomorrow? Viraj is not going to use, I know that. Viraj, I want to ask your opinion on this process model also, but first, Dr. Poonam Patil.
I am not sure whether I would or I would not.
Okay. Viraj, what is your
Also
thought process? Yes, ma'am. Yes,
also, the etiology of underlying chronic liver disease was also important independently. If it was related to hepatitis B and hepatitis C, sorafinib had benefit compared to the other chronic liver disease, which we are more often seeing now in India. We are seeing more often NASH-related CLDs
you are right.
rather than
Absolutely
hepatitis.
right. So true.
Madam, so you are not going to do an extra test. So among the routine tests, so you can select out patients. So like we are doing for a Child Pugh score or a BCLC. So why
Yeah.
not this into, and this can help some patients. At least
Ghanshyam,
in the
we
first.
look forward to you. You can start using this model and then tell us in the next meeting what Viraj organizes, that what is your median overall survival. Viraj, you can take this as a point. Viraj,
Right.
what is your thought process about this mathematical formula? Is it just a device formula or it makes sense?
No, definitely it makes sense. This categorizes them to a good prognostic cohort. But my thing is, these 42 patients who did for 16.9 months would do equally well or better on lenvatinib also.
Wow, Viraj, we should have a debate about lenvatinib versus sorafinib. But I agree with you, Viraj. You know, going by the data what we have so far by lenvatinib, it definitely scores little better over sorafinib. In terms of the sorafinib is much cheaper compared to lenvatinib. Still, you know, that is something. People who can't afford immunotherapy is out of question. So, Dr. Rishabh, do you check blood pressure in first 2 weeks of TKI, and if hypertension, do you feel very happy about it?
Sir, I do check. I tell them to maintain a blood pressure
No,
chart.
first 2 weeks. First 2 weeks.
Yeah, so I do check it, but for prognostication, I'm not very excited if hypertension is there, which was not there before. Though we have data that with hypertension prognosis may improve, but I'm not very sure because BP check and managing it is more important to me rather than prognostication.
Okay. Dr. Venkata, Pradeep, Babu, you have started sorafinib. Patient can afford little bit of lenvatinib also. But within 2 weeks, you see hypertension. Would you be happy continuing on sorafinib? Or if the patient is affording lenvatinib, you don't mind shifting also to lenvatinib?
For just patient has developed a hypertension, so that is the need, not that should not be a reason to shift the TKI. In fact, as Dr. Rishabh rightly said, patients who are developing hypertension, it might be a surrogate marker that patient might have good result, like a rash in TKI in lungs. So definitely we try to control the hypertension, but as you said, might be I'll be little happy to see that if patient develop hypertension.
So
Okay.
Amish,
Yes, Ghanshyam.
so my patients with or without sorafinib, with or without hypertension. So before they see me, so they usually have a high high blood pressure.
I think that is true with all of us. So let us discuss Child Pugh B, first line. It's advanced HCC. The category what is available is sorafinib. Then we have nivolumab and we have FOLFOX. These are the three which are approved drug. Will anybody give immunotherapy atezo-bev in Child Pugh class B, especially B7? I heard about lenvatinib. Many of the panelists would give lenvatinib, but would anybody give? Let's start with Dr. Poonam Patil. Ma'am, would you give atezo-bev in Child Pugh B?
Again, a very fluid situation, but I might give.
You might give. Okay. Dr. Chitij, is very important. That's why I want to ask all the panelists.
Practically speaking, this is a very expensive drug, and if some complication happens, then there will be a problem. So I will stick to the indication.
You would stick to the indication. So one yes, one no.
Amish.
Dr. Ghanshyam, yes or no?
So my experience, at least in double figures of nivolumab. So people, and at least I'll tell you a center in Delhi who gives left and right, a GI center, and he's my colleague also. So he says he has a good experience, but at least my 10 patients, first line, second line, this drug doesn't work at all, nivolumab.
Nivolumab does not work at all in the first line. Okay. Ghanshyam Biswas, sir, would you give atezo plus bev combination in B7, yes or no?
Yeah, if the patients, I mean, the GC is good, because B7 is very subjective, as we discussed.
So you would give.
Yeah, so we can give it. Yeah.
Okay. So 2 for yes and 1 for no. Dr. Viraj, yes or no?
Yes.
So, okay, 3 for yes, 1 for no. Dr. Rishabh?
Tempted medically, but not given yet. I'm afraid more medico-legally.
Okay, so 3 yes, 2 no. Dr. Venkata, Pradeep, Babu?
So very costly medication. So patients like I'll go by the rules. and
So
So,
3
made a
yes
good.
and 3 no.
Venkata, Assam Cancer Center will give it free next year.
Yes, sir. Sir,
I'll-
nivolumab
I'll-
is already free.
I'll tell you, there are few review articles on this, and I think from the medical perspective, what the scientists have defined B7 into two categories. One, B7 is because of cirrhosis or the underlying liver damage. Other B7 can be because of tumor itself. So if it is because of tumor itself, if the liver function test is relatively normal and if the platelet counts are normal, you are justified in giving atezo-bev in these patients. That is what all the experts, they say that. Okay. Let's move on to, I know this is what we have discussed. I just wanted to take Dr. Viraj Lavingia's very quick take on LEAP 002. Although it is, phase 1-B, but OS of 22 months with a disease control rate of almost touching 70 to 80%. Are you tempted in any of your relative or friend who are not going to sue you to use Pembro plus lenvatinib in first line HCC?
No, I have not done that because I'm convinced about atezo-bev, and I think they are more or less same. Lenva-pen or atezo-bev or durva-tremi or Nivo-ipi. I consider all four in same basket.
Atezo-bev does not have TKI, Viraj.
What is it? TKI.
Atezo-bev does not have TKI.
Still a VEGF, right? So the mechanism is the VEGF reduces your CD4 and Tregs and unleashes the immunotherapy. So that is what Bev is doing in atezo-bev, and that is what TKIs are doing in those combos.
Correct.
So Amish, I was a
am a
part
big
of the
fan.
Himalayan
Yes.
trial.
Okay.
Yeah, so I had 4 patients, but truly speaking, because that was a three-arm study, so one arm had a sorafinib. So in my 4 patients, so one patient had sorafinib and rest 3, the combination. So nobody had a response.
Okay. Right. So let's wait for that. I think, please remember Lenva plus Pembro in metastatic RCC has unprecedented overall survival. Yes, Viraj.
Important point in a chat has been raised, what Dr. Biswas was saying. Nivolumab the approval has been withdrawn by the US FDA.
I'm coming to that. That is, nivolumab is not withdrawn in the first line. Please remember that, Viraj. It was April 2021. I have a slide. So we are coming to the second line treatment of advanced HCC. I have 3 to 4 minutes more and I'll finish in that time, Viraj. I know you are also looking at the clock. People have to have their dinner. So we have 3 large randomized trial, and based on which we have category 1 approval, that is regorafenib, cabozantinib, and ramucirumab. And based on non-randomized trial, we had nivolumab and we have pembrolizumab, and we also have some interesting data with Nivo plus EP. And please remember that what Viraj was telling, that April 2021, the ODAC committee voted 5 against 4. It is not an outright vote. It is 5 against 4 against nivolumab. Contrary to what Dr. Kancham has said, I have had good response with nivolumab in HCC. I have got some good, as the data suggests, 20 to 30% is the response rate, and people are going to live longer if they have a good partial response. That is what I have observed with nivolumab. So I don't agree with ODAC committee. Nivolumab still remains one of the good choice in advanced HCC. So that is what I wanted to say. Dr. Poonam, this is the data on Nivo-ipi. I'm jumping the guns because we have little time. And if you see the median overall survival in patients who has CR or PR, you see the graph in yellow on the right-hand side. This is amazing. In a third line setting, once the patient has exhausted first and second line, would you be interested in trying out this? This also is approved by NCCN panel as 2A, 2B. Yeah. Dr. Poonam.
Yeah, I would be tempted to use if the patient is in good general condition and can afford.
And can afford, yes. Because the data is unprecedented. Dr. Kshitij, have you used or would you use Nivo-ipi combination?
So we have one trial Nivo-ipi for RCC going on in our MOC. So I have a good experience with that, but I have not used in HCC. But I have seen quite a few number of Nivo-ipi without any side effect, and some have very good responses in RCC. But HCC, if the data shows, I would like to use.
Okay. Yeah, this combination has been working in lung, RCC, and So maybe, maybe, but down the lane in the third line, so how many patients with the performance status, with the liver function? So that will be the.
No, you are absolutely right, Ghanshyam. But those who reach there and those who can afford, we have an option of Nivo-ipi in this particular regimen. In fact, it can be used in second line also if the patient is afford and fit. I just wanted to show that this is something which is there in RCC, which we have forgotten now. Please don't forget that sorafinib followed by regorafenib, people are living beyond 2 years. So just because somebody can't afford immuno doesn't mean that the things are lost. Does Dr. Venkata Pradeep Babu, do you use FOLFOX anymore in HCC? Yes or no? If yes, what is your experience?
No, sir.
No, you don't use it. Okay. Viraj, do you use FOLFOX?
No, sir.
No. Any panelist is using FOLFOX? 2 months back, I used one patient FOLFOX because this was couldn't afford any immunotherapy. We gave first line and second line TKI, didn't work, and finally FOLFOX. Patient was alive for 4 months. That is what my one experience.
So when sorafinib is not available.
No, that is not the case. So, I would like to conclude this session. MDT increases survival in HCC. Child Pugh score is for liver damage following cirrhosis, but does not assess damage related to tumor. Please remember that. First line sorafinib is the only category 1 approved in Child Pugh B. Atezo-bev in Child Pugh A, I think all of us know, has surpassed the best results with this combination. In TKI, lenvatinib scores over sorafinib, which we all know, and we prefer lenvatinib over sorafinib. Sorafinib followed by regorafenib, people have lived beyond 2 years. Cabozantinib remains category 1 in second line. Ramucirumab we could not discuss, but it is approved if alpha-fetoprotein is more than 400 and in second line. Nivolumab has been withdrawn in the second line HCC. Sorafinib pre-treated in April 2021. I don't agree with that because I have got a good response based on the literature. And there is very promising results seen with combination of Nivo-ipi in sorafinib pre-treated HCC. And please keep that in mind in patients who can afford. Those who respond, they are going to do very well. FOLFOX remains one of the options.
So Amish, I have a comment.
Yes, Ghanshyam.
Yeah. So as TP said, no. So it is because of a late Dr. GS. So we are in a trial, me, Sailesh, I don't know if you are there. So that was a BT122. So that was a metastatic SCC in the time when we didn't have a second drug. So we started with the lower dose of sorafenib of 200 BD and we added beta blockers. So that was propranolol and we added celecoxib. And in those patients who had a bone metastasis, so they were given a prolonged infusion of evanuronic acid. And you won't believe, so I had 2 patients who are 70 years plus, they survived for 3 years.
Wow.
With a good quality of life. So this was before the era of lenvatinib.
Dr. G.S. Bhattacharya used to love beta blockers a lot, and he would always tell me that if you are using beta blocker, keep the pulse rate between 60 to 70 and don't let it increase beyond 70, otherwise you would lose that. Anybody, any other panelists, any comment? Otherwise, over to Viraj to conclude the session and the day both.
Sir, to you,
Yes,
because there are
Venkata
so many learned panelists, I just want to ask one question. Are anybody using capecitabine in a jaundiced HCC patient when we are unable to give any TK? And one more comment I want to add is in the LEAP-2 data which you have shown, pembrolizumab plus lenvatinib, the results are really extraordinary, sir. In the trial, they have included even glioblastoma and very resistant cancers beyond the when adjusting all the standard lines. And even then, somehow, even in MSS patients also, MSS stable patients also, the results are really excellent. So that is one combination maybe that will pave its way. So regarding capecitabine, I want to.
Dr. Venkata Pradeep Babu, you are absolutely right. I think TKI and IO combination mein lenva plus pembro is going to score over others in next 2 years' time. That is what my gut feeling is. About capecitabine in liver deranged, let's start with Chitij.
I have not used capecitabine.
You have not used. Dr. Ghanshyam?
I don't remember I have used. So if there are no choice, we can use it at a lower dose, metronomic dose. Why not?
Okay. Dr. Poonam Patil.
A very low dose probably is what they might be able to tolerate. Otherwise, it's like 5-FU infusion in FOLFOX.
I agree with you. So, Dr. Venkata Pradeep, I have used FOLFOX because FOLFOX does not have any upper ceiling for bilirubin. It can be given. I have given in other diseases FOLFOX with 15 and 20 bilirubin also, and people have tolerated it quite well. In HCC, I have used FOLFOX 1 with bilirubin of 5. Patient did respond well, and then we shifted to TKI in that patient. Last word from Viraj about capecitabine, and then Viraj, please conclude the session.
No, sir, I have no experience of chemo in HCC at all.
Okay, excellent. So Viraj, over to you. Thank you so much for inviting
But
me.
Amish,
As always, a
till
pleasure.
2008, so even after DM also 5 years, we have used only chemotherapy. And that was gemcitabine and PLD only.
Correct. Absolutely right. So
At
true.
least
So
just to ask one,
8 years of initial career, we have used chemotherapy only. And
so true.
okay, so can I ask one question practical? If the patient is in front of me yesterday only, HCV positive, HIV positive, HCC with progressed on sorafinib with bilirubin 13.
and
That's
also
supportive care
and also
or anything?
COVID positive then.
Best supportive care or anything we can give it to him?
Supportive care. It's easy.
Best supportive care, but Kshitij, it all depends on CD4 CD8 ratio. If it is controlled HIV, you can treat like any other HCC with deranged liver function test. And this particular patient, if it is controlled HIV, I would not hesitate to use FOLFOX if the performance status is good.
So, thank you.
Viraj bhai, last and final time, please take over.
Thank you, sir. Thank you, Dr. Amish, and thank you. Wonderful panel discussion on advanced HCC.